I'm the founder and president of Dysautonomia International. I'm coming to you from my den in New York, and we are really happy to be joined by Dr. Alissa Zingman this evening. She's going to talk to us about dysautonomia and EDS and the sort of structural and biomechanical relationships that affect these conditions. And she's really great. If you don't know who she is already, she's a board certified physician with 9 years of experience and training in orthopedics and preventative medicine. She earned her MD at the University of Maryland School of Medicine and went on to academic orthopedic surgery residency at the University of Rochester. She completed her residency in preventative medicine at Johns Hopkins. And then before medical school, she was a professional dancer and a Pilates instructor. She did her undergrad at Columbia, and she is, really sort of understands what our patient community is going through because she, lives with some of these conditions, and she's pretty open about that. So I haven't outed her. Um, I also, before we kick it off, she's just finishing up something with one of her slides needed to get fixed. But before we kick off, I also wanted to just plug our conference is coming up. If you haven't heard about it or have never attended, it's a really wonderful, like super supportive educational event. It is in Raleigh this year. We move it around the country. And it's the largest conference in the world on autonomic disorders. We get about 500 people in person and a couple thousand people tuning in online. So there's online and in-person registration options. You can find out more about the conference at dysconf.org, dysconf.org. I'll put the link in the chat later. It's just awesome. We have clinician education courses for medical professionals. We have patient and caregiver courses. We have a teen program. We have all of the research updates you could possibly imagine on POTS and other dysautonomias, long COVID, EDS, Sjogren's, lots of all the different comorbidities our patient communities have. All right, I think Dr. Zingman is ready to go. So I'm going to turn off my camera and pass it over to you.
I'm Dr. Alissa Zingman. I used to be in practice for 9 years. I should probably update my bio because time keeps marching on. And I was diagnosed by Claire Francomano with Ehlers-Danlos Syndrome in 2017. Like many of you, I'm sure, that diagnostic journey was not brief nor pleasant until I finally met her. And she very accurately predicted that I might eventually need a port, which I now have. And I'm actually infusing as we sit here. And she referred me at my first visit to Fraser Henderson, who I did not go see for quite some time, but I did get diagnosed with cervical spine instability, CCI, by him at that time that I did finally meet him. And lots of other things happened along the way. And 2 years after my diagnosis, I started the practice, P.R.I.S.M Spine and Joint, thinking it would be a relatively low-key endeavor, and that I probably would work 3 or 4 days a week because how many people would have this rare condition? And that was not how that went. So we now have a relatively large multidisciplinary practice with 5 physicians and a full rehab staff and integrative acupuncture. And I'm not sure that I had ever heard of POTS. In 2017, I honestly, I don't know if I had. I'm pretty confident I'd never heard of MCAS though. And now, that's what I live and breathe all day long. And I certainly am positive I had not heard of lymphatics, which is in this talk. So I'm excited to share all of this with you all. I started out in orthopedics. I was a dancer. Biomechanics, kinesiology is sort of my, foundation, and adding all of this stuff to it and learning about the interplay with everything. As a patient, has been a very mixed bag, but as a physician and caregiver has actually been a tremendous joy because I think that there is such a huge positive impact that working on the musculoskeletal system can have on these other diagnoses. And I think that that's just a huge area of potential that is often untapped. And it's exciting when we can tap into that a bit and people can get a little bit of a result that they maybe didn't even know that the possibility for that was there. So here we go. Lauren, I want to double check that I have this is an hour. Is that
Yep.
correct?
Yes.
Great. Okay, here we go. All right, we're going to talk about hypermobility and sagittal balance, posture, alignment, brainstem, autonomics, hypermobility, breathing, and fatigue. Going to get into spinal cord, CSF, and lymphatics a little bit. Very brief touch on blood flow. And then see if we can make it to clinical practice at the end. So a lot to cover. I don't know if we'll get to everything, but I'm pretty confident we'll at least make it up to the clinical practice part. All right. Why is it so hard to remain upright? So human beings, we are built to resist gravity, but when we're hypermobile, resisting gravity seems to be really hard to do. And I use this analogy a lot of that this is light, right, for a minute, but if you had to hold it there for an hour or 2 hours, it gets really, really heavy. And with hypermobility, it seems like that time window to when resisting gravity gets really heavy is shorter. Um, the fatigue hits, the muscle recruitment just seems to escape us. And our breathing patterns tend to start to go into a very compensated pattern. And I'm actually a little, because it's the end of the day, you're going to hear my breathing over the course of this talk, so I apologize for that. And our proprioception is a lot of times altered. And we get into these compensation patterns, inflammation cycle. And why is that? Why are we struggling with that? And what can we do about it? And what effect is it having on us if we're not addressing it? So a non-hypermobile person has a very easy job. A toddler should be able to do it. They're stacking wooden blocks, right? But when you're hypermobile, everything has a lot more degrees of freedom. And so it's more like stacking water balloons. And stacking water balloons is something that needs to be constantly tended to, right? It requires much more attention from the nervous system. And as you'll see as we go through, there's research that shows how cognitive tasks are affected in people with EDS if they're having to be upright while doing them with or without POTS, just because of the musculoskeletal effort and the cognitive effort of trying to maintain posture. Um, and so there's this extra energy being spent, and you can kind of, if you think of it that way, see how, oh my gosh, yeah, of course my muscles are getting more tired. Of course, my nervous system is fatiguing. And we haven't even gotten into, the blood flow issues. That's not the main part of this talk, but it's certainly a factor, and I don't want to neglect it. I'm not going to focus on it for this talk. So this is sagittal balance. Sagittal plane is the wheel plane. And when we talk about biomechanics, we need to talk about all the different planes. But for today, the purpose of today, this is really the one that I'm focusing on. And it's basically if we looked at a person from the side, we want the weight of their head, rib cage, pelvis to be balanced over the ankle foot. And so that's a plumb line. Plumb means if I had a string and I hung a little weight from it, where gravity would take it, that is the perpendicular plumb line. And that's the line at which those things should be balanced. And something I like to say is like, if the rib cage were a funnel and the pelvis were a bowl, and we poured water into the rib cage, all the water should go into the bowl of the pelvis. And if you're thinking about this a little later or you want to make a little note to yourself, something you could kind of do is have someone take a picture of you from the side. And if your rib cage is kind of like this, and your pelvis below it, if that's your front, is kind of like that, the water, if it was poured into the funnel of your rib cage, would all end up in front of you on the floor, not in the bowl of your pelvis. And same thing if we have that pelvis kind of tucked under, right? Then the rib cage like that, we don't have that plumb line. And then where are we balancing our weight? What are we using and what structures are being strained and how is that impacting us? So I call this hinge theory. Physioline is sort of the method that I came up with. It. I actually don't describe it in this talk. It's not the point of this talk, but there's a website if you want to look it up on sort of how we approach these patients to sort of demystify how physicians, physical therapists, and other healthcare professionals can approach these patients, hopefully without getting too overwhelmed, but also without neglecting things that need to be addressed. So the hinge theory, it was just sort of my name for this, but it's basically that when we have pathologic hypermobility, because, and this person actually is very mild hypermobility and isn't actually one of our patients. It's a friend. But even with this person, we can see, you know, if there's some hypermobility right here and they kind of sink into that spot, then they have a little bit of a straight segment above it, right? So if there's one area where there's a little extra motion, that area has some hypermobility and it is sunk into it, so that rather than things being balanced and tensioned in a more suspensory type of way, they are at end range of motion or going toward end range of motion there, and then collapsed into that, then we're not going to have a situation where the balance of the weight is no longer over the foot because we'd fall down. And so we have to make it up. So that's where we get this kind of straight segment. And then we have to have a hinge in the other direction. And then we have to make that up and again. And that's where I'm going to show you in the next slide. We always end up kind of paying the piper in the neck. And when we pay the piper in the neck, it creates a huge problem because the head weighs a lot. And the junction of the head and the neck is an area that has very minimal bony constraint, right? And when we have hypermobility, our joints that have a lot of bony constraint, meaning the bones, the way that they are interlocking makes them very stable. And we're not relying on a tendon or a ligament, a soft tissue structure made of non-bony collagen, right? Of soft tissue collagen. We're not relying on that to keep the bones together, right? Those are going to be more stable. So a hip is a good example. We will see a lot of soft tissue injuries in hips in patients with Ehlers-Danlos syndrome, but we don't see a lot of frank hip dislocations because the ball actually has a relatively deep socket to sit in, as compared to, for example, the shoulder, where we see lots of subluxations and dislocations because the socket only covers about 15% of the ball. And there's a lot of degrees of freedom, and we have that full sort of circle of motion. And when we think about the head neck junction, and I'm not going to turn my head because I learned this lesson finally to not do that during my talks. But you know, if we think about how far the head can turn, and I'm talking in a healthy, non-hypermobile person, that is a lot of motion, and it's mostly happening at C1-2, and then the flexion extension, a lot of it is able to happen right at the head neck junction. And the bony constraints there are pretty minimal, and it's really soft tissue constraints. It's those like nice thick ligaments that are present between the head neck junction and between the first cervical vertebra and the second cervical vertebra where they overlap. And so because our body wants to make sure our eyes stay nice on the horizon, because that's a very important thing for our vestibular system to keep our balance, it will kind of make our head end up kind of straight. And when our head goes forward so that we correct ourselves right at the top, what we're ending up doing with that forward head is creating this very heavy load because of this lever arm by not having the head right over on top of where the thoracic spine, that's the part of the spine that is part of the chest, by not having the head over the thoracic spine. And you can see how every time you go forward, the weight of the head experienced by the muscles increases so much, and how fatiguing that would be, even without all the other stuff that I'm about to show you happens as a result, just from the work of carrying so much extra weight. And so this is a representation of a person who's not even hypermobile, but I think that probably if you've been to a doctor's office where there are a lot of EDS patients, or you've been to a conference, you've probably actually seen that this is actually like a more sharp angle almost, and here too is like it's almost like more like a hinge, right? And of course it's not a true hinge, it's just like a concept to help like visualize. And so again, our clinical experience is that at that head neck junction where there is all that freedom, all the degrees of freedom, that we really see that that area takes a beating. And this is hopefully I've noticed I need to update some of my pop culture references. This is a JFK reference. That's not where your neck can do for you, but what you can do for your neck. But this is kind of what I was saying, where we kind of think about it like this. And then right here is where this picture, I think, doesn't show what would really happen, because this head would be straight. And even in old pictures of polio patients where their spine's totally curved all the way, the head is straight. This is a picture of CAA, stands for clivo-axial angle. And this is a clivo-axial angle that is pathologic. This is from a research study, that's the journal. And this is a preoperative. This patient in the study was operated on. And this right here is the brain stem. This triangular bone here is called the clivus. It's the base of the skull right in front of the brain stem. Where's my cursor? There she is. And this is the cerebellum. And I'm going to point all these structures out to you again. It's not the only time I'm going to show this picture. The white here, that is the cerebrospinal fluid. And we can see in this person who, it looks like in this picture to me, this person's not even dropping their chin to their chest. This is just their straight position. Like this is what they look like straight. And that means that they don't have any ability to sort of lengthen. Here, it's just fallen. And the white, the CSF, cerebrospinal fluid, there's just not any space for it to circulate in the front here. And not only that, but this angle that the actual neurologic tissue at the junction where the brainstem becomes the spinal cord, it's not supposed to have to bend like that. It's supposed to be relatively straight. And so if you think about a softball game and somebody's bicep gets hit with a softball, right? And the next day it's really bruised and, it feels bad and it's all swollen, and it would be hard for them to pick up a weight and do a bicep curl, or it might be hard for them to pitch a game that day, right? Well, that's what's happening to this neurologic tissue constantly over and over again in this scenario. And another thing I like to say is, a muscle sometimes will take a joke. Nerves don't take a joke. A nerve does not it does not take a bruise lightly. And so when we think about what is happening here with this tissue, we have to think about what is the function there. And this is the spot where all of the information from the body is going back to the brain, and where all of the information from the brain is coming down to the body. It's also the spot where we actually have the neural tissue of the actual brainstem right where that circle is. And so I included what some of that brainstem tissue does. It's this tissue right here, okay? Right, this is the bottom of the brainstem, and then the yellow would be the top of the spinal cord. And that is where the body regulates breathing, heart rate, and blood vessel function. So if we think about dysautonomia and we think about the cardiovascular function and all of the things that are the symptoms that we know are challenging for patients who have POTS and related conditions, we're thinking a lot about stuff that is regulated in part here. And I say in part because even if this area isn't affected and is working perfectly, there are other ways for those functions to be dysregulated. They could be dysregulated due to issues elsewhere. And so this is not the only way for them to be dysregulated, but it's certainly a good way for them to be dysregulated, because if this tissue is undergoing chronic repetitive stress and inflammation, then the tissue is maybe not going to be functioning properly. And you might also imagine that this could be a dynamic situation. And so when the alignment is better, when inflammation is lower, for whatever reasons, based on activity going on, based on other factors related to inflammation going on with the person, that might have to do with seasonal allergies, might have to do with exposures to various different things, that the symptoms might really be variable. It's sometimes compared to other times. Maybe the person's working really hard in school or at their job and they're looking down a lot, and now their symptoms are a lot worse. And they're like, all I did was sit there. Well, but they were looking down, and this was getting more and more bent and bent and pushed, right? So understanding how the anatomy and the biomechanics ties in with the anatomy and the function of that neurologic tissue is, to me, a very powerful piece of knowledge that can help us learn how to regulate and manage our condition. Going up from there, by the way, just a little bit above, we have breathing, hearing, taste, balance. And so those are also with the upper cervical instability, because the nerves that come right out from here, they come right down, right through here. And then they go to the ear, and where they need to go, because our ears are very involved in regulating balance in the vestibular system. So that's also part of it. So this doesn't show like the full anatomy and everything. And there's certainly like a lot more nuance and complexity, but I just really want to kind of like get the points across about how the musculoskeletal system and posture and alignment and biomechanics is very, very, very important. This was a little fun I had. I made this just for today. Let's see if it goes well. So here's that same picture. Now, sympathetic, parasympathetic, sympathetic, fight or flight, parasympathetic, rest, digest. That's the autonomic nervous system. For this talk, I did not sort of like spell that out and make separate slides on that, because I wanted to get into a little more like detail. But the cranial nerves and the sacral nerves are the parasympathetic, and the vagal nerve comes from there. And then the sympathetic nerves come into play in the other areas of the spine and the spinal cord. So here is the cervical ganglia. Okay. And this is a very important part of sympathetic nervous system regulation. And so our sympathetic is our fight or flight, right? So if we want to be able to get up quickly and have our body say to our blood vessels, squeeze tight because we got to get the blood all the way up to the brain. We don't want it to all stay in the legs when this person stands up. This is part of where the some of that signaling is going to come from. And with what we were talking about with kind of the hinges and, pinched areas and everything, it's not only here, although in this person, it kind of is only here, but in other people, it's not only here. We can have lots of pathology in terms of alignment all through here, herniated discs, or just angulations, even without herniated discs that are very diseased. And also stenosis, it could be narrowed here. And then I did a little overlay, so right here, that's sort of like the sinuses. So that's the maxillary nerve sphenopalatine ganglion. Here is an important part of sort of the vasculature going in, but the real thing, and I couldn't make them like line up perfectly because they're, not drawn by the same person at the same scale, but you can see this is where all of these nerve roots would be coming out. And this is, I believe, C7, T1. I think when I counted earlier. And so if there's pinching of these nerve roots, if there's constant movement, that shouldn't be happening there, whether it's in a rotational plane or, things are just stuck, jammed, and nerves are getting pinched, they're getting inflamed, then the body might be getting some stress signals from that, or it might be impaired in its ability to give proper signaling to the body with regard to what is needed. So, all right. This mostly just shows that, and that continues down through the rest of the spine, because I'm going to be able to get to other topics other than just that. Oh, this picture doesn't show. Oh, that's okay. So there's also, I mentioned I was going to kind of like very briefly touch on blood flow. So this is really the only slide on that. Because that is much more related to rotational instability. And that's not my main topic today, but this is the vertebral artery. The primary blood flow I'm going to go right back to here. So the primary blood flow you get like the main part of the brain, the part that is not really shown much in this picture because I cropped it, is coming from the carotid arteries. The posterior circulation, and that is supplying this back part. A vision is back here in this area. And then of course the cerebellum, balance does help with memory, some of that brain fog type stuff. The posterior circulation comes up through there, and then they kind of join in this like kind of circle. It's called the circle of Willis up in the middle. And the posterior circulation goes through these foramen just means hole, in the vertebrae. And you can kind of imagine if this C1 turned really far, right? And let's say where my thumbnails are, okay, is where the holes are, the foramen that the artery went through. So if it's only supposed to turn that much, then that is the distance that artery is supposed to have to, quote unquote, stretch, right? So it's supposed to have to stretch that much. But let's say instead of only turning that much, it turns that much. maybe the artery gets kinked and the blood flow gets compromised. And so with that, people might experience things like when they turn their head, their vision narrows or darkens. They might experience that when the vertebrae get kind of stuck in that position. And so they're kind of stuck with this sort of slightly grayed out type of feeling, the poor balance, the sort of like bumping into the side of the hallway and the door jam, and the peripheral vision isn't great, and the proprioception and balance issues, ringing in the ears, is another big one with that, coordination of the eye movements. And those, there are a lot of symptoms that can kind of come along with that. There's also issues with, and that was the other picture that that isn't showing, but with blood flow out of the brain, because we need to be able to get deoxygenated blood away from the brain so that we don't get high pressure and we can get nice, fresh, oxygenated blood up. And so with instability, we can have misalignments, tight muscles, pinched things, and the jugular veins sometimes can be impaired. What's really interesting is that, oh, this is a fun picture. But what's really interesting is that vascular surgeons will, interventional radiologists will actually use jugular veins as grafts. So in healthy, well, not healthy because they're needing a vein graft, but in people without EDS who don't have a problem with their jugular vein, there are actually some surgeries in which the jugular vein is harvested and used as a graft, to replace a section of vein that was diseased and had to be removed, like let's say in the groin, so that a person doesn't lose their, their leg, or need a hemipelvectomy, like removal of a piece of their pelvis and the whole leg. And according to two surgeons I know who do this, it's fine, and they don't need their jugular vein, which I find very fascinating, because I certainly, that's certainly not my clinical or personal experience in Ehlers-Danlos patients, who I think sometimes have very significant symptoms from venous outflow problems. And so I think that there's more to be understood there of why that is so different in different patient populations and what exactly is going on there. And my guess is that it's probably multifactorial, because probably all of the different things that we're discussing here add up, and we probably don't understand a lot of them fully yet. So, and maybe there are some that we don't even know about that, we give this talk. If I give this talk next year, I'm sure I'll have to update it quite a bit. I had to update it today, actually, because of some research that came out in March that I hadn't read yet. All right. So anyone who has Ehlers-Danlos syndrome and has been to physical therapy has done breath work. I'm just checking how I am on my time. Oh, okay, we're pretty good. Here. So, and anyone who has tried to do breath work has had this feeling, I think. If you haven't, by the way, good for you. The rest of us are very jealous. But yes, I think I'm stuck. I cannot breathe into that area. Is that even possible? Can other people do that? That type of feeling, right? So the comma between breath and work is quite intentional, because it really is work. And so why is it so hard to breathe? Let's first watch a little video. So I want to talk about what's supposed to happen when we breathe. So here's what's supposed to happen. The rib cage is supposed to expand by getting wider and going up. Now, in this video, the clavicles are moving a little bit. I don't think they really need to move quite this much, but the main point is that when you inhale, this here is the diaphragm, okay? The diaphragm drops. That's what drives the inhale, is it creates a vacuum. It's negative pressure. Diaphragm drops, creates a vacuum, negative pressure. The negative pressure causes the lungs to fill. And then the exhale, the lungs shrink back down and the ribs come into that exhalation position. That means that they are coming lower, right? And more towards the middle. What should not be happening is that the spine has to arch, right? So like that shouldn't need to happen, and this shouldn't need to happen. Um, and let's talk a little bit about why those things happen sometimes. So, and I'm going to get to this second one shortly. So, um, now for a pause for a moment. When we are teaching someone biomechanics and breathing, we, at least in our clinic, and we don't only teach it one way, because the person might need to learn to breathe into this area that is the restricted area. And so belly breathing is not the kind of like it has an X on it in this physiologist's photos, which actually really like this person's photos. But belly breathing is a great thing to work on sometimes, right? Apical breathing, I don't really know when we would work on that, but maybe there's someone who works on that sometimes for a very good reason. And sometimes, one of the things we work on here is breathing into your lower back, and breathing into the bottom of that rib cage and widening it, because a lot of people, their floating ribs are in this very externally rotated position, and the angle between the ribs here, which should be on most people more like this, is actually kind of like that. And the muscles just like the fibers can't reach each other at all. There's just no way to get those muscles to start to engage and support the spine, right? But when the involuntary breathing is happening, when the person is walking and they're doing their activities, when I'm sitting here talking to you, when you're sitting there, lying there, standing there, whatever you're doing, listening to, someone talk and show you some pictures, and you're breathing and you're not consciously, right, doing something as a breathing activity, it should be happening as diaphragmatic, and your spine should not be changing position. So if the pelvis is at some sort of weird angle, and this comes back to the rib cage is like a funnel and the pelvis is like a bowl. So whether you're inhaling or exhaling or holding your breath, that should still be true, that if you poured water into the funnel, it would end up in the bowl. So why would we end up kind of opening up in the front, squeezing sort of the pelvis open at the SI joints, and splaying the front even in the pelvis in some cases, squeezing the glutes, shrugging the shoulders, squeezing the shoulder blades back, and really almost, I call it like a spatchcock, like a chicken, like almost spatchcocking open, in order to make room for our lungs to expand. And why would we end up lifting up and arching our back, whether we're doing it in the upper back, the lower back, or even kind of trying to do it in the lumbar, in order to make room for the lungs to expand? Why would those things be happening? So sometimes it's because of the pelvic floor. There's a lot of different reasons why it could be. And so this slide is a quick reminder that it's all connected, because the contents of the abdomen don't change just because we're breathing. Oh, I have a chat. Oh, okay. No, don't need to pause for that. I agree, though, the conference is phenomenal. Okay. So yes, the contents of the abdomen, they're not changing. All the organs that are there are still there. All the, gas and everything else isn't changing just because we took a breath. And our body will allow the intra-abdominal pressure to increase, but it won't allow it to increase beyond a certain point. And so what our body will do if the pelvic floor is tight, and the pelvic floor isn't compliant, is it won't let the diaphragm really drop. And so the diaphragm will start to go down. Well, the pelvic floor should also go down, right? And they should be in concert. And if they're not, and if the pelvic floor is really tight and it's kind of, more like a snare drum and it's not compliant, the diaphragm can't really sink. So why would the pelvic floor be tight like that? It could be tight like that because of some SI joint instability. It could be tight like that because of a pelvic floor issue related to pregnancy, unfortunately, trauma. It could be from something that the person doesn't even know, that it has just been around for a really long time, and they're not aware of, because it tends to be a very neglected area. It could be because of a hip issue. I mentioned earlier about, labral tears, being, not in any way uncommon in our population. It could be because of some biomechanics going on in the knee, ankle, or foot. There are just so many reasons. Shoulder biomechanics can really affect what's going on in the pelvis on that same side. And cranial bone movement, and pelvic bone ilial movement, definitely, in osteopathy, mirror each other and are worked on together. And there's just so many different things. And so when we're working on a structure, we really want to work on the whole structure. If someone was trying to make the Leaning Tower of Pisa straight, you wouldn't tell them they're only allowed to work on the top eighth of it, right? Like, that just doesn't make any sense. And so I think that sometimes we get a little hamstrung by the fact that our insurance model restricts us to, you can only work on the injured area. And so fields of study tend to focus on protocols that are what is done, and what is done is what insurance will cover. And so it gets really, I think, a little myopic there, where we might be dealing with a thoracic spine problem or a neck problem, that we need to address something that's affecting the pelvic floor, and that could be the great toe. So it's really important to kind of, I know this is sort of like a little almost sidebar slide, but actually it's a really important slide, because everything really is related. It's very important. Okay. All right. Next. Oh, okay. I think I covered it. All right. So here we go. This actually kind of shows what I was talking about how um, we don't want to have to be moving the alignment of our spine in order to breathe. And while this is actually the purpose of the person who made this image was to show improper alignment, what I really, really love about this image is that it kind of shows how you can, when you change your spine alignment, even though they didn't really make the rib cage change that much in their picture, which it would based on what they have the spine doing. Like here, the spine's pretty straight, but they have this rib at the exact same angle almost as this one, which it wouldn't be based on the spine being at a different angle. But this one, it's more closed down, right? See how the rib cage is more tilted down there, So if you look at these things, you can really see how, if you imagine a lung inside of here, this posturing where it's kind of collapsed forward is going to be a little hard to expand. And this one where it's lifted up, you don't have a lot of place to go, right? Because you're kind of already here. And in this, where it's pointed into the bowl of the pelvis, it almost it feels like it can expand. I don't know if looking at it accomplishes that for everybody, but I can see a useful slide. Okay. Cerebrospinal fluid. All right. So I'm going to pause for 1 second in case there's questions on what we did so far, because this is sort of like our little next chapter here. Okay, and keep going. Okay, checking time. Oh, okay. All right. I think I'm probably gonna end about 8 minutes late. So, alrighty. So here is our brain. And remember that picture from before with the craniocervical instability. And I had mentioned how the white in that picture was missing right here. And we really want the whole brain to be bathing in that cerebrospinal fluid because that's where all the nutrients are getting from, but well, and the blood, but that's where all the waste is being um expelled. And that part is also important, and that's also lymphatics. And it's very important to kind of get all the circulations, the blood, the lymphatic, the cerebrospinal fluid, everything. We want the brain to be able to get what it needs, and we want the brain to be able to expel waste. And that's all very, very important. And you can imagine any pinching here, right? Anything compressing could disrupt this flow. It's not a ton of room there. All right. Glymphatics. Okay, glymphatics are, I was really excited to learn from Lauren today that Dr. Goodman actually gave a Dysautonomia International talk on lymphatics recently. So please check out that talk for a more comprehensive and sophisticated look at lymphatics. Lymphatics are so fascinating, and like what we know now compared to what we knew even 6 months ago or a year ago is so it's just evolving so much. Actually, same with CSF flow and the relationship between heart pumping and CSF flow, the relationship between breathing and CSF flow. Just in the past year, so much new information is coming out all the time in these topics. So lymphatics, amyloid. Amyloid is a substance that, if you're sort of into following health news, you might have heard of, or if you're in the medical field, because it's very tied with dementia. And so it makes it into the lay press quite a bit. And the lymphatics is how that's expelled from our brain. And so it's not quite the same as lymph in the rest of our body, but it's got a similar sort of feel and flavor. And it's very important in terms of removing um like molecules that will accumulate and cause issues in our brain function. Um, and so again, amyloid is sort of the most commonly mentioned one because again, we just know about it so much in terms of the dementia. And the lymphatic drainage, again, is very tied to intracranial pressure. Intracranial pressure, if our venous outflow is obstructed or compromised, up it goes. Cerebrospinal fluid flow compromised, up it goes. And so all of the ways that we've discussed that the biomechanics, the spinal alignment, the breathing, and all of that can affect what's going on in the neck and how our head neck junction is going to be one of the places where we do the most compensation to make up for it. That is all going to affect all of these other things. And then we're actually going to get an accumulation potentially of molecules that we're going to have maybe some difficulty clearing out. And excuse me, There's a technique in osteopathy called the Perrin technique. It's not the only technique, but there are some techniques in manual medicine that people are experimenting with to improve flow. There are certainly alignment techniques. There's obviously the option for people who have severe instability for fusion. There's also just so much that is available in terms of let's decrease inflammation. Let's see, is there gut inflammation from H. pylori, SIBO? Is this person gluten or dairy intolerant? And we just haven't addressed that. Do they have a dust allergy? And we don't have a dust mite zippered cover on their mattress and pillow yet, because I mean there's so many simple things that can be tried from an inflammatory standpoint, from a biomechanics standpoint. And so I really encourage everybody to, start if you can by reaching out, find a care team, talk to your care team about, hey, what can we do? And, if you need the interventions, by all means, right? Because everybody is different. And gosh, when you need neurosurgery, there's nothing like a neurosurgeon. God bless, right? That is just such a when we have patients who need neurosurgery and they get what they need and they're better, it really it's just the hugest relief, right? Um there are so many people who I think also think that there is nothing other than that. It's that or it's nothing. And so I don't want anyone to think it's that or it's nothing, because there are a lot of people who will meet with a neurosurgeon and the neurosurgeon will let them know, no, you don't need a surgery. We're not there. Or the person, it doesn't want, to pursue that. And there are a lot of simple things: working on breathing, working on biomechanics. This is the study I was talking about actually with the cognitive tasks. And so the breathing is really when the patient was doing a cognitive task, the hypermobile patients actually had more difficulty with their breathing. I mentioned I was going to come back to that other video. I'm going to do that now. Here it is. And this is very cool. If you have not seen this yet. Wait a minute. That's not the video. Hold on. Where is it? Is this it? By the way, this is what I had to remove from my talk because in March, an article came out that refutes it. So who knows what the next article might be a tiebreaker. Here's the article. I think this is the one that came out in March that refuted it. But oh, here's the one that I wanted to show you guys. Look at this. This is so cool. That is the white stuff, is cerebrospinal fluid pumping. Leave that on for a minute.
We can't see the videos, just so you know, if you're showing the
Can't?
video. Yeah.
Oh no. Oh my goodness. Let's fix that. Hold on. Stop share. This video is so cool. We have to share it with you. We must. Here we go. Hold on, hold on. How do I exit my slideshow? Okay, there you go. you see the video now?
No, I think you've just stopped sharing the slides and maybe share either your whole desktop or the window that has the video in it.
Now, can you see the video?
I think so, yes. Wow, that's cool. Okay.
Yeah, it's great. And play it again. Really cool. I think this is actually probably a good stopping point for us for today. What do you guys think? You see this
Yeah.
again?
Do you have a few minutes to do questions?
Absolutely.
Okay, we don't want to keep you too late, but I think there's a lot of
I,
great questions in here.
I
Let
can
me
talk
try to
about
pull some of that video is awesome. I gotta go find that on
isn't that cool?
Instagram.
It's in the links in my PowerPoint. Let me show you that other video that I showed you guys that you apparently didn't see while we're sitting here. Oh, that's not it. That's it. So this was the one of the diaphragm dropping and the ribs kind of coming out and up. Yeah.
All right, I'm going to jump into some questions. And I know probably each of these could be its own lecture, but let's try to get through a whole bunch as quick as we can. um, can scoliosis be a sign of EDS?
Oh, okay. Well, that's not a yes or no question. So
Told ya.
there is a type of there are a lot of different subtypes of EDS. So there is a type of EDS, levoscoliotic EDS that is, or kyphoscoliotic EDS that is associated specifically with scoliosis. Um, there is scoliosis that has nothing to do with EDS. And then there is the fact that people with EDS have bones that are more likely to sort of wiggle waggle. And so there's a lot of what I call functional scoliosis that can happen in EDS, which I've actually had very good success in sort of helping get it a little bit better and more aligned because there's more movement.
I thought that question was really interesting because I just got asked this week to lecture at there's a patient org called Curvy Girls. It's like a scoliosis patient advocacy org for young girls with scoliosis.
Cool.
And they asked me to lecture on dysautonomia and EDS at their conference this summer. So
I love
I'm like,
that.
I think it's the EDS connection is why they're telling me they're seeing,
Yeah.
dysautonomia folks in their patients. All right.
I'll try to find it while you guys are talking. I have a really awesome picture. I'll try to show you, but I'm listening for the next question.
Okay, great. Do you have advice for patients with EDS and or POTS who are hoping to pursue medical school and a career as a physician?
Ooh, well, oh, here we go. I found the picture. So, do I have advice? Well, gosh, that's also not a quick answer. You were right. So I think that things are so different now, thank goodness, than when I was in school. I'm kind of getting to be like a dinosaur, I think, because when I was going through everything, like the kiss of death would have been to tell anybody that you were sick or ask for an accommodation. Like you couldn't do it. And so now I think that young doctors in training actually are able to ask for accommodations and receive them. I'm certain that it's institution dependent, it is situation dependent, and it's probably not equally um available everywhere. And so I would say that probably the best thing that you could do is find other people who are doing it, who are going through programs and requiring accommodations, whether it's for EDS or something else. And find the communities. I think with all the online communities available these days with like Inspire and Reddit and whatever, social media, and find out their experiences. And it's probably going to be about like finding the school that's gonna work with you. And I think that that is available now. And I also think the osteopathic schools are probably going to be a better bet than the allopathic ones. University of Michigan or Michigan State has a PhD, I forget her name, who's has a podcast and is like very dedicated to this topic. Do you remember her name?
No, but I do know two of our hardcore DI volunteers for many years who we met as teenagers. One has an MD and one has a DO, and they're both POTS patients who still have POTS. I think I know one of them has EDS, the other one might. And they got through medical school. It's definitely not easy. I don't think medical school is ever easy. Certainly not when you have a health issue to manage. But and we know a couple other POTS, EDS, mast cell folks who are in medical school or getting their PhDs and MDs, and it's awesome to see that because I think that lived experience makes you a better doctor.
I think so too. It was just so like it's so hard for me to answer that question because when I was in medical school, like if I had a fever of 104.5, I just had to pretend I wasn't sick and go do whatever I was supposed to do because it was just, they were like, no, you were sick last year. That's it.
Yeah.
You know?
Do you have if in like a 1 minute explanation of a helpful breathing exercise to try to help people breathe better?
I do. I actually do. Okay. I'll demonstrate it. I can. Okay. So, hand here, and then a hand kind of right below, if you're a woman, the bra line. If you're a man, feel for kind of like your points of your rib cage, like here. And feel those points of the rib cage. Okay, and then a hand here. And what we're gonna try to do is have the top hand, which is on the sternum, sink a little bit so that we're not in this sort of I'm pushing my chest up and squeezing my shoulder blades together position. And then the bottom hand, okay, we want to let that kind of fall a little bit too, not in a collapsed way, but just we're moving forward so that rib points are now more over the front of our pelvis. So we're not sitting all the way back on our tailbone. We're sitting more toward the front of our pelvis. Okay, so pubic bones and sitting bones are touching our chair rather than sitting bones and tailbone. And then when you breathe, see if you can breathe into your pelvic floor. So your pelvic floor actually drops into the chair. And this hand here and this hand on those rib points don't have a super, super ton of movement because you're letting your diaphragm drop and you're letting your pelvic floor drop into the floor. And the movement's happening by your rib cage expanding out to the side. And if you can feel when you inhale, that your pelvic floor kind of drops into your chair a little bit, and that you get a little wider rather than having this kind of stuff happen, then you did it.
I did it. I
Yay.
think I got dizzy because I got too enthusiastic and I was like breathing extra. Um, but it was great. Okay. And then sort of a similar question, like, are there, I know the answer is yes, but what are the ideal, like, simple at-home exercises people can do to improve their spine stability?
Ooh, okay. So the one we just did, first of all, nothing in this talk is medical advice. Everything you run by your care team, physical therapist, doctor, everything. Okay. Um, what we just did, the easiest version of that would be lying on the person's back. Some people will need a little kind of like ramp because when they lay on their back, like the bottom part of their rib cage is like way off the floor. You have to have the bottom part of the rib cage into the floor. And so some people, in order to have the bottom part of the rib cage to the floor, they need a little bit of a ramp to get, almost like their head is right of the bed is elevated like 30 degrees type of thing, 45, whatever is comfy. And then the easiest version would be you're on your back, your knees are bent, and feet are at like 90 degrees. It's called hook lying. So like this would be the feet and they'd be against like a wall or something, right? And the knees would be supported. And then this would be the hips. And then this would be the upper body with a ramp if
Like
needed.
putting your knees up on a couch.
Your head. Yeah, you can use like a couch. Ideally, you want your feet to be able to like push into the wall. So you have something like a little solid. Like a Pilates reformer would be the more advanced version. Um, and it's what we just did. And when you do your inhale, you really get the rib cage in the back to go into the floor and expand wide. And when the exhale happens, the front is kind of like knitting together a little bit. And on each inhale, that's happening even more. And you, as you keep going, your exhales get deeper. So you're not losing what you gained with each exhale every time you inhale. Because when people first start, every inhale, they kind of lose the muscle tone they got on the exhale. And what should end up happening is that the sides, like from the armpit down to what I call a tuxedo stripe of the pant, all the way through the feet should start to kind of lengthen and there should be some pressure. And then that kind of grows into like what you do on a Pilates reformer. And before it does, it grows into what we just did in the chair and then a sit stand, right?
Mm.
And so a sit stand is like a perfect, I mean, we all do it every day, right? So a sit stand going from what we just did, maintaining that and taking it into a sit stand is a very nice thing to do in a nice controlled way, weight evenly on both feet, making sure you're not on your heels, you know.
Yeah. All right. This is the last question, and it's definitely not a yes or no answer, but it's a good one. Could postural alignment problems in EDS patients lead to vertebral artery dissections or contribute to it?
Huh, okay. Um
Mhm. Easy, easy last question.
so what was could postural
Could
alignment
your postural alignment like being really messed up in an EDS patient like
so
increase the risk? Maybe we
so
don't know.
yeah, so the complicated question because like the first thing I think that is really important to note is that there are two main things that we know for sure increase the risk of vertebral artery dissection. One is that vascular type Ehlers-Danlos increases the risk of dissections. And that's not specific to vertebral artery necessarily, that's just the condition, right? And then the second thing is high velocity, low amplitude neck cracking. Um, so those are two things that we don't have any doubt. Those are two things that create risk of vertebral artery dissection, right? And so I think that probably this person is wondering if the HVLA is giving them an increased risk of vertebral artery dissection because they have the HEDS. I'm guessing is where that's coming from. Um, and I don't know that anybody knows the answer to that question. I don't. Um, I do know that HVLA shouldn't be necessary to get your neck aligned. There are like other ways to,
HVLA is the high velocity,
yeah,
low amplitude, like
it's like, yeah, of
what
the neck.
some chiropractors do.
Yes, yes, yes,
Yeah.
yes. And there are other ways to get the neck aligned.
Yeah, great. Thank you so much. This was a great talk. We had so many questions we couldn't get to, so I apologize to everyone. There's always more that we can get to, and I feel like we could keep Dr. Zingman on the phone for the next 24 hours answering questions. But you know, she's great. If you, I don't know if you do if you're taking patients right now. I know all of the clinics that are good at
So
this are
we
busy,
yeah,
but she's got a clinic if anyone wants to consult.
yeah. No, yeah, we have a pediatric doctor, we have pain management, sports medicine,
Awesome.
PM&R,
Yeah. It's
integrated.
so hard for patients to find doctors and other providers that really understand the stuff, and it can be scary to go to a doctor who doesn't know it and then like take their advice and like, you don't necessarily always trust it if the doctor doesn't really have that expertise. So very much appreciated. For anybody who's joining that it has not really been part of Dysautonomia International before, we have support groups in all 50 states, all Canadian provinces, and like 60 other countries. You can find them at dysautonomiainternational.org/support. They're free to join. And we have local meetups in person and virtual. We have like regional events. We're doing some political advocacy at the state level, well, at the federal level, but organized by state. So we encourage everybody to get involved and just stay connected with our fellow patients and kind of hear what's going on. And we try to share the research through the support groups too, as much as possible. But thanks so much, Dr. Zingman. Have a good night.